So next is Parkinson's disease, which again, we're in our neurologic disorders. So the pathophys of Parkinson's is this is a disorder that occurs in the brain, specifically in the basal ganglia, the substantia nigra, which is this part right in the middle. It's right where the brainstem kind of interacts with the rest of the brain. And what happens in there is the production of dopamine, that neurotransmitter, is inhibited, which causes an imbalance between a dopamine and acetylcholine. We do not know why this happens in patients. So etiology, unknown. We have no idea. It does appear that there is a genetic predisposition, so that Parkinson's does tend to run in families, but we do not know that for sure. It is a progressive chronic disease, just like MS. So patients that do get diagnosed with Parkinson's, they're going to be living with this long-term, chronic, progressive disease for the remainder of their lives. So we do need to make sure they understand the scope of this diagnosis. For assessment, there is a hallmark triad that we observe for in patients with Parkinson's. Akinesia, so the absence of movement. This is most noticeable when they're trying to do things. So they can't do it. There's just no movement. They'll look at a pen in their hand and say, I'm going to write this down. And nothing will happen. So they're not able to complete the movements even though they have the intent to do so. This can also be around walking, which for healthcare providers can be really frustrating. We can get a patient up out of bed and say, okay, we're going to walk to the chair next to your bed, and they'll just be like, and they won't be able to make that first step. It's that absence of movement. Rigidity is also another thing. So they have these, what we call cogwheel movements. So if you move their arm through a range of motion, most noticeably with passive range of motion, it's not going to move smoothly like this. It's going to go kind of jerky in what we call cogwheel. This can progress to a contracture. So eventually that kind of jerky movement can just be tonic all the time, resulting in contracture. So we do always need to move patients through passive range of motion if they're not able to do that for themselves. And also bradykinesia, so slow movements. This can appear, it can look like they're messing with you, to be honest. Because some of the times I see this most commonly with Parkinson's in the hospital is when you give patients medications. You go to hand them a cup of pills and they're just like, slowly reaching for it and very deliberate with their movements. And it feels like it's like, come on, keep going, keep going, keep going. But that bradykinesia is a very, very common hallmark symptom of Parkinson's. They're just not able to produce those movements at the same rate or pace that somebody who's without this disease, who's neurologically intact, could. They also have these pill rolling tremors. So at rest, their hands will do this kind of motion. It's almost as though they had a capsule between their fingers and they were just kind of rolling it all the time. That's a very common one. And a shuffling gait. So you'll often see them kind of hunched over, and it's so funny because it's always like these little old guys. Kind of like imagine the guy from Up when he's got his walker and just kind of like, doing his thing like that. That's that classic kind of shuffled gait that patients with Parkinson's have. It's just that kind of thing. It's just a classic presentation of Parkinson's. So infographic about all those kind of symptoms that patients are going to have with the muscle rigidity and that cogwheel movements, their tremors, especially those pill rolling tremors, very, very common, and the bradykinesia, that's very, very slow, deliberate movement. The difficulty initiating that movement are very, very common hallmark symptoms for Parkinson's disease. And this guy's wearing a mask because part of that kind of difficulty initiating muscle activities or movements pertains to their face. So their skeletal muscles on their face are always just like very flat, very relaxed. So it can look almost mask-like they're not very expressive. So that's why he's wearing the mask. So for the medical diagnosis, Honestly, there's no objective data that we can say like, yes, that is Parkinson's. It's not like it is with MS where we can get an LP, analyze the sample and objectively say, yeah, you have MS, things like that. It's really a diagnosis of omission. So we take into account the clinical picture and we rule out everything else that it could be. So patients will be ruled out for things like MS. Those tests will all be negative. And we may end up saying, well, it's most likely that you have Parkinson's disease because we've ruled out every other thing that it could be. Parkinson's, unlike MS, is most common in men and over 60 years old. So this is a disease of advanced life or further down the life cycle than MS. We're definitely not looking at our young childbearing ages. We're looking more at retirement ages. H&P, we're looking for clinical presentation, meaning when we examine them, are we seeing those tremors, shuffled gait? Are we seeing those slow movements? The cogwheel movements is very much used as a diagnostic, and we're looking for that symptom triad that we talked about in our assessment phase. The other cool, well, it's kind of cool, but it's also kind of creepy thing that happens is we test them for a response to anti-Parkinsonian medications. So when we give carbidopa, levodopa, when we inject those drugs, it'll eliminate their symptoms temporarily. So they'll go from that mask, kind of cogwheel, pill rolling presentation, we inject this drug, and for a short period of time, they will be completely neurologically normal. They will move appropriately, they'll be expressive, all their symptoms will go away. Unfortunately, because this is a neurotransmitter, we're talking about dopamine as a neurotransmitter in the brain, we can't really supply that in any kind of meaningful long-term environment. So even the sustained release tabs, they have peak onset in 2 hours. When we're doing this kind of test for the diagnostic phase, we give an injection, and within 15 minutes, all their symptoms are gone, but within 20 minutes, they're back to normal. So they have this very kind of quick elimination of symptoms, and then they go back to their regular presentation. We just can't provide the level of medication in a safe manner that's going to alleviate their symptoms long term. So it's really hard. It's really, really difficult to manage the symptoms for Parkinson's disease because of that. We just can't do it. So here's kind of what we see on MRI. So this is a normal brain, so this is normal activity in the brain. For a patient with Parkinson's, we can see there's decreased hotspots in the brain. After we give them the levodopa injection, it goes to this. So we can see that these hotspots return and more closely mimic a normal cognitive ability, not necessarily cognitive, but like physical ability in the brain. But we can't sustain it long term. So it's going to go back to this depressed neurologic activity pretty quickly, regardless of whether we're doing the trial for diagnostic or whether they're on long-term treatment. So some of the nursing diagnoses, the things that we're going to appreciate when we're caring for these patients: imbalanced nutrition, less than the body requirements. This happens for a couple of reasons. One, the very slow movements. It takes them a long time to eat. And if they're in a care environment, part of this is our fault because we don't provide them the full amount of time they need to get their full caloric intake. And after 30 minutes of working on a food tray, most of the time we're removing that food tray to send it back to the cafeteria to be cleaned. We're not giving them the full amount of time they require because of their bradykkinesic movements. Self-neglect, again, as their muscles start to deteriorate, as they're not able to perform those movements as effectively, they're not going to be able to take care of themselves as well. At risk for falls is a big, big one related to their shuffling feet. That shuffled walking pattern, very, very high risk for tripping over anything on the ground. Impaired physical mobility, again, that shuffled gait, absolutely one of those hallmark signs of Parkinson's. So for the medical plan, physicians are going to be writing prescription in order to replace or supplement dopamine in the central nervous system. But we do know it's not going to have a full restorative effect. It's to help minimize the symptoms that these patients experience. So it's very, very much supportive, right? We're also going to be looking at other supportive measures to prevent complication. Because this is a central nervous system disorder, it's going to affect the entire body, meaning both intentional movements and autonomic functions, right? So airway management is a big, big thing, keeping their airway open. They're going to have decreased muscle tone to their tongue. So choking is a much bigger risk, or aspirating on their tongue is also a big risk. Decreased facial muscle tone, so, that mask appearance. Like outwardly and socially, it's a physical abnormality that we're going to see. But one of the big concerns is they're not able to manage saliva in their mouth. So there's a very high risk of aspiration around not being able to mobilize some of those oral secretions to swallow them. They can very easily aspirate any liquid that's in their mouth because they just don't have the muscle movement to do it. They're going to be on, every time I say that, it's like I gotta swallow just to, prove to myself I'm okay. They're going to be on dopamine therapy. There's going to be that bolus dose, which is going to be used for diagnosis. We want to see immediate return of normal neurologic function, but it's quickly going to go away. Then they're going to be on a lower long-term dose for management. Other experimental therapies that are going on, a limited extent in North America, but pretty extensively in other parts of the world, deep brain stimulators, which are almost like TENS units, like those little electrostimulators for muscle pain. We can use those in the brain to help manage some of the tremors, and patients are having some success with these devices. So that could be something that we see coming in the future around management of this disease. For our nursing plan, it's a chronic progressive disease, so supportive measures are a big thing. Emotional support is just as important as physical support. Because patients are going to have physical limitations that they weren't planning on at that phase of their life, and they're going to keep getting worse, we want to make sure we're addressing the emotional component as well as the physical. When we address the physical, we want to always keep an eye out, do these patients need physical therapy and occupational therapy? Physical therapy is really helpful early on in their presentation of Parkinson's because that's going to help with like gross motor movements, right? Like getting from this side of the room to that side of the room. Occupational therapy is super helpful for the entire duration of their disease process because they're more concerned with like fine motor skills. So things like adaptive equipment to help them eat and maintain as much independence as possible. As nurses, when we're caring for these patients, scene safety is a big, big thing. We want to make sure the scene, the environment of care, is safe for that patient to be in it and encountering healthcare or just living their normal life. So we want to words can be hard. We want to pay close attention to things on the floor, including rugs, cords, anything on the floor, and just watch out for it as a tripping hazard. Because of that shuffled gait, patients aren't going to pick up their feet to step over anything. They're just going to shuffle and keep kicking it. So we don't want anything that's going to be down there that could potentially trip up their feet, cause them to fall down. Also nutritional support, because it takes so long for them to eat, we want to plan small, frequent meals throughout the day. Also high calorie, high nutrient content foods for these patients. So our dietitians are an outstanding resource in care planning for these patients. So again, just kind of the non-motor, the non-neurologic musculoskeletal presentation, some of the other things that can happen with advanced progression of Parkinson's disease. So for implementation, when we're providing care to patients with Parkinson's, some of the things we want to do, we want to manage the complications. Patients are usually not hospitalized for Parkinson's disease. They're hospitalized or they're encountering medical care for a complication of that disease. So whatever that secondary problem is what is the reason that it's developing? It's for a fall. It's for broken hips because of falls. Things like that are the complications of the underlying problem, which is their Parkinson's disease. And what are the goals of care? So similar to our MS presentation, do they want to continue to receive curative versus palliative? Have those conversations been started? All the same resources that we would use for our MS patients, we want to use those for our Parkinson's patients. People like chaplain services and the palliative care teams are great, great help when managing these progressive neurologic disorders. Same thing also with the caregiver role strain. The really sad thing I see with Parkinson's disease patients is you see, this cute as could be little 90-year-old guy with his walker shuffling along, the guy from Up, just kind of shuffling along, being grouchy, all that kind of stuff. And his also just as old wife, arm in arm, kind of walking down the hall with him. It's really tragic to see these things playing out, but we want to make sure that it's still appropriate for that also frail caregiver or partner to be providing care to that patient. We always want to assess for whole family safety, not just for the patient. So that's it for Parkinson's disease. It's a heavy one, so we'll end on a light note. Next, we're going to be talking about CVAs or strokes.